So conventional imaging, there's a lot. This is a hot topic, and the one study I'll point to is from a performance standpoint, PSMA clearly does better than conventional imaging, and this comes from Mike Hoffman. It's called the ProPSMA Study, 302 patients, direct head-to-head comparison between conventional imaging versus PSMA PET. PSMA PET blew it out of the water with regards to accuracy, 92% versus 65%. Had a greater treatment impact, which we could argue here, does it really lead to improvement in outcomes or not? And it had fewer uncertain results. So, we joke in radiology that the radiologist's favorite tree is a hedge. We don't have to hedge as much. That joke didn't work that well. All right, detection rates. So when you compare PSMA versus fluciclovine, this data shows that it performs a lot better than fluciclovine. Now we're going to shift to sort of the use of PSMA PET, and according to some of the different appropriate use criteria out there. It's important to recognize now that the NCCN, our radar group, multiple different groups now clearly show that conventional imaging is not required prior to MTI. In fact, at initial diagnosis in those patients who are unfavorable, intermediate, or higher, and at biochemical recurrence, getting conventional imaging prior to MTI is a colossal waste of resources. And I think insurance companies were pushing back in the middle, but in the beginning, but I think now they're understanding that listening to the physicians will save them some money. Now they listen. So it's not required prior to MTI. Conventional imaging is not recommended in low or intermediate risk patients, which we talked about in that RADAR 1 article. But then MTI is recommended in unfavorable, intermediate, high, and very high risk patients. So it sort of fills in that gap where, and we know again, MTI typically performs, not typically, does perform a lot better than conventional imaging. Conventional imaging is rarely positive in patients with a PSA less than 20, whereas MTI has a detection rate of around 50% in patients with a PSA of less than 0.5. So magnitudes lower, performance much, much better. So from a performance perspective, I think it again, does a lot better. Future directions. I admit, and in my talk, I also said that it's not ready for prime time when it comes to response assessment. That being said, there's a criteria proposed out there called RECIP, Response Criteria in Prostate Cancer. And a lot of new research being incorporating using serial PETs to look at response. And I think it's showing greater and greater signal that it is a reliable tool to look at response, and in many ways reliable and more accurate. And in future areas, local disease evaluation is going to grow. So in some ways, this actually might replace MRI. And I think Dave, without us even planning this, talked a lot about how PSMA is changing how we evaluate local disease and local recurrences. I think the biggest problem is financial considerations. And probably like 8 years ago, I presented at one of Dave's meetings about sodium fluoride. And I used an argument about sodium fluoride replacing bone scans. And if you actually looked at the cost from Medicare reimbursement, at least according to one local MAC, it actually was equivalent with the bone scan and a CT versus just a sodium fluoride PET. The difference here is PSMA PET is the PET CT technical component plus the radiopharmaceutical charge, which is expensive. Sodium fluoride was dirt cheap. It might have been like $100, $200. The radiopharmaceuticals now are probably in the thousands range, maybe $3,000, $4,000, which changes the calculus or the arithmetic. So I don't know there. I don't know what's going to happen there. That being said, I do know over time these will become cheaper, and that delta between a bone scan and CT versus a PSMA PET is going to be much smaller. And at that point, it's a no-brainer. It's very interesting to know that across the globe, PSMA PET is utilized much more differently. In Australia, it might be $500 to $1,000 to get a PSMA PET. I know in Latin America, it's probably around $600 or $700 last time I went there. And it's completely, it changes the discussion completely. There, they were getting PSMA PETs left and right for every indication, following patients, and it didn't really matter. So I think what we're going to see is, these countries, they're going to continue pushing this envelope forward. They're going to use it for response assessments. They're going to publish on it. And then at some point, we're going to have to make a decision on how we move forward in the United States. So hopefully that's convincing argument that PSMA PET, that conventional imaging is obsolete.